Thank you. Good afternoon, everyone. My name is Daniel Keszthelyi. I'm a consultant gastroenterologist at the Maastricht University Medical Center in the Netherlands. And first of all, I'd very much like to thank you for the invitation today, allowing me to speak to you about functional GI disorders. And I hope you're having an excellent conference there in Cairo. So these are my disclosures, just very briefly for your reference. What I'd like to talk to you about today is giving you some guidance as to how to manage a patient with functional GI disorders in clinical practice. So this is something that I was definitely not taught during medical school, and I was very much appreciative of the guidance that I actually also received from my tutor. So this is something that I would like to share with you today. When you're talking about a patient who sees you at the outpatient clinic due to abdominal complaints, generally speaking, the patient will have three questions to you. First of all, what is it that I have? Why do I have this condition? And thirdly, how can I make it go away? So in fact, you will have an effective consultation if you're able to answer all three of these questions, generally speaking. So in order to give this kind of a framework, I've come up with a set of simple rules, so to speak, based on the prototype of functional GI disorders, which is obviously IBS. And I've called these the 5 golden rules of IBS that I'd like to share with you right now. So rule number 1 is, and probably most importantly, is to use the positive diagnosis. So the positive diagnosis, by that I mean the Rome criteria. And it's very important to communicate this diagnosis, in this case, the IBS, to the patient at the very first consultation. So that's also something that's part of this positive diagnosis. And this will eventually get you to a more rapid and effective treatment. So this is opposed to the alternative in which you first see the patient, the second time you see the patient back because you've done some examinations, and then you tell the patient, well, there's nothing wrong with you because then we didn't find anything. So that might feel very delegitimizing to the patient. So this is the very great advantage of the positive diagnosis. Now, obviously, you all know the Rome 4 criteria, which were published in 2016. And what you should notice is that all these criteria are actually based purely on symptoms. So there's no additional investigation whatsoever that is part of the diagnostic criteria. And what you may also be aware of is that these criteria change from time to time. So you might recall the Rome 3 criteria, which were in 2006. And there's quite a difference between the Rome 3 and 4 definitions, the Rome 4 being far more restrictive. Now, this doesn't mean that these patients from one day to another don't have any complaints anymore, don't have IBS. Well, formally speaking, they get a different diagnosis. So in this case, you can see functional constipation or functional diarrhea or some other functional disorder. So that doesn't really mean that they're cured or anything. So the concept will still remain the same. And for clinical practice, you should be far more liberal as to applying these more strict criteria, in this case, the Rome 4 that are actually more meant for research purposes. So rule number 2, limit the extent of investigations. So what's very important to understand and realize is that the diagnostic yield of many investigations are actually quite limited. And it could give the patient a cue to pursue an endless round and quest of investigations looking for something abnormal, just to be sure that you really did find something. And this is also something that will not necessarily lead to either patient or practitioner satisfaction. So just a small example from a study recently published from a British group. And this is something that they did in patients with IBS. And what you see here is the bottom line of the conclusion is that in those patients who did not have any alarm features, so that being rectal blood loss, weight loss, etc., which are very important to look at, obviously. So in the absence of those symptoms, the diagnostic yield of the colonoscopy in IBS was actually 0. And if you look at this from another perspective, this is also a fairly recent study from from a Scandinavian group, that you can see that if you compare the positive diagnostic strategy as to the more traditional exclusion type diagnosis, that you will actually end up with the same amount of endoscopies, the same amount of investigation. So it's not necessarily something that is wrong. And one very important thing to remember is that the colonoscopy per se is not a treatment. It will not make the patient better. On the contrary, it will actually increase patient burden, because obviously colonoscopies are not particularly pleasant to undergo. And this is a US study, somewhat older, 2005, in that you looked at the reassurance rates related to colonoscopy, and you can see that there is no difference there. So the colonoscopy itself is not even a treatment in terms of reassurance, not mentioning the fact that it doesn't really have a diagnostic yield in many cases. And the exact same holds true for dyspepsia. This is a Dutch study from 2006. And here they looked at organic abnormalities that were found on upper GI endoscopy and people with just functional dyspepsia. And you can acknowledge here that there was no difference in terms of anxiety, depression, pain scores, or health-related quality of life following the gastroscopy. So the upper GI endoscopy was not reassuring in these patients either. So the main message is here, an endoscopy does not treat the patient per se. So what you can think of in terms of IBS, going back to IBS, and some of these investigations is actually something called the 4 C's. So that's calprotectin to rule out IBD, celiac screen, which is somewhat higher prevalence in IBS than general population, CRP to look at inflammation, obviously, and you should reserve colonoscopy only in case of these alarm features of left-flank conditions. And you should talk about the patient, talk about this with the patient as to what the a priori chances are of finding something in relation to the burden and the potential complications. And the patients will generally understand that this is not something that is absolutely necessary. So how you could communicate this to the patients is that you can say, well, I hear your symptoms. They are indeed real. So it's not something that you just made up. And the symptoms you're experiencing are compatible with something we call IBS. So we're going to go do a few simple tests to make sure there's no other underlying cause to your problems. And in the meantime, you can already introduce some of the potential treatment options that there are that the patient can think of whilst you are waiting for the exams to come back. So rule number 3 is also very important, and that's addressing the patient's fears and potential misconceptions. So by that, I mean that many people have the notion that abdominal pain equals cancer or abdominal pain equals polyps, which is obviously not the case. So you should explain that to the patient, and you should also be aware of your own insecurities and the fact that there's a symptom-based diagnosis obviously is something that is inherently insecure in the sense that you don't have a biomarker or some other very firm diagnostic procedure that you can adhere to. So generally speaking, when a patient comes to you, they will be in this phase of their disease, which is low self-esteem, helplessness, vulnerability. And this is when your own insecurities from the patient side, I mean, will actually contribute to increasing patient burden. You can see this blue line being the pain intensity, and obviously there are some predisposing factors and precipitating factors like infection and major loss. And in the end, you come into this green area where you can actually treat the patient and make sure the patient gets better. So rule number 4 is you should explain to the patient what the gut-brain axis is and how visceral sensitivity can lead to pain symptoms and what the factors are that actually can trigger these pain symptoms, such as stress. So by that, I mean that stress is a factor rather than the cause of IBS. And this is something that patients will appreciate, because it's not that you're saying it's all stress. No, it's visceral hypersensitivity, which is causing the symptoms, which can be exacerbated by stress. And this is a very busy diagram. Obviously, it's from a fairly new review that was just published in Gastroenterology, and you can actually appreciate how complex this whole idea is, not only of IBS, but more general functional GI disorders, which are now actually more often referred to as disorders of the gut-brain interaction. So that is actually a term that I very much like, because it encompasses all kind of different pathomechanisms that are going on both from the gut side as well as from the brain side. And if you look at that in a more historic perspective, then you can appreciate here that in the early 1950s, 60s, there was more a motility-based idea as IBS was concerned. And now in the more modern era, so to speak, you can see that the visceral hypersensitivity and to a greater extent the gut-brain interaction, and I should say the gut-brain microbiota interaction, is something that has become more or less the most popular pathomechanistic explanation for IBS. And rule number 5 is when you counsel the patient in making their own treatment choices, it's very important to practice the modern terms of patient empowerment and shared decision making, because these will actually make sure that the patient will eventually adhere to a certain therapy. So if you're prescribing a certain medication that the patient just does not feel comfortable with, then obviously he or she will not take it, and it's not going to help. So it's very important that you try to investigate what the patient's preferences or beliefs are. And for instance, many people will not believe in hypnotherapy, but others will be very keen on trying it. And there are people who generally prefer pharmacotherapy, for instance, and there's a lot of options, obviously, that you can advise in that sense. And this is a nice diagram that I'm showing you here as to how can I advise the patient as to what kind of therapy am I advising. And what you can see here is this is a diagram that divides the symptoms into mild versus severe, and transit type symptoms like diarrhea and constipation, and more perceptive type symptoms like abdominal pain and bloating. And what you can see here is that peripheral approaches are generally more suitable for symptoms that are more transit related, so diarrhea and constipation, so think laxatives or antidiarrheals. Whereas the more you get to the perceptive part, so the abdominal pain part, the more you are actually looking into neuromodulators, which is here termed as antidepressants, but I think the more modern term for that is neuromodulators, and also more behavioral type therapies such as cognitive behavioral therapy or hypnotherapy. So I've summed it all up in this infographic that I made for this presentation, and I will share this with you via social media. And this is basically, I think, the main things that you ought to adhere to when you are seeing a patient. And this will not only make the patient very satisfied about the treatment you've given, but also yourself. So I hope that this is something that you can also agree upon and find it helpful in your everyday practice. So that was what I wanted to tell you today. If you have any questions, I'm obviously free to answer them right now. And otherwise, you can always contact me via Twitter, or you can drop me a line. Thank you very much for your attention.